I have to compliment you both on being incredibly efficient and doing some great abstracts in record time. I want to encourage the 290 registrants, including all those online, to please submit some questions via the chat function. Can anybody here come up? While we're waiting, I'll just ask maybe one. This is probably an equivalent question for Doug, but in the Lisa Straight Nurses Health Cohort study, do you really believe that that observed effect would be real? And I say it's equivocal because those are all great things to tell patients that we'd want to do. But in terms of the 60% of people who have diverticulosis, telling them if you do these things, you'll prevent diverticulitis, and here's the effect for an observational study, when there could be so many confounders there, because those are going to be sicker people, people who smoke, people who are obese. Is that real? And I guess one way they could have teased it out would be if they had evidence on complicated diverticulitis and showing a similar effect for just garden variety. I went to the ER, they told me I had diverticulitis.
Yeah, I mean, good points there. I think what you're suggesting in the latter one is if they kind of look for an interaction in a way and split complicated for uncomplicated to see if the kind of variables work in the same way. And I honestly don't know whether they've done that and whether they should do that. Obviously, I can't speak for them, but that's an interesting idea. I think to your first point, it's well taken. It's observational data. But, I would say that this is some of the best observational data we have, right? Like I am showing you the 5 variables that they ended up with. This is this nurses health study where they have everything from shoe size to zodiac sign, right? I mean, they control for just about everything. So yes, it's observational data, but it's some of the best observational data we have. So, and again, I think you're right. Again, for the interested patient who's asking you what to do, this just kind of feeds into the normal narrative. What I normally tell patients is whatever you think about is good for your heart is probably going to be good for your colon as well. So just do those things and hopefully you'll live a little longer.
Okay, I think Dr. Sultani was first.
Just a quick question. There was a mention of left-sided diverticulitis. Would you treat a right-sided diverticulitis patient differently than a left-sided? And in terms of what is your threshold in practice? How many attacks does a patient have to have before you send them to surgery? What's your folks' practice?
I mean, I can go first and, happy to hear what others think too. To your first point, I mean, I think the most important thing, I think you know this, that's why you're asking the question. I think the likelihood that diverticulitis is more severe if it's on the right. And so I think more careful, more close follow-up, a heightened level of concern for people with right-sided relative to left-sided diverticulitis is important. Whether you actually change your management, for example, starting antibiotics earlier, I don't think that that's true. There was actually a wonderful at DDW. And again, for those that registered, you can go see there was like a sold out conference about the management of diverticulitis, and maybe that was specifically covered. So I think that's some thoughts about right-sided and left-sided. I don't know if you have any other concepts about that, but I think they're definitely more severe, but I don't think that there's, oh, and then in terms of surgery, definitely there is a move towards less and less surgery, being more patient, going to surgery later, right? It used to be this old dictum that if you had one and then a second one, you had to get your colon out. I think people are largely moving away from that. And again, if you do go to your best of DDW, they actually did present kind of the likelihood of people recurring, and it's like 30% at 2 years or something. I mean, again, the idea that if you have a second episode, you have to get surgery, I don't think that that's correct.
I'll go to the Clipper fan in section 2.
Thank you. And the paper that showed the increased risk of colorectal cancer in patients that have acute diverticulitis, be it uncomplicated or complicated, that relative risk was between 2 and 5, right?
Yes.
But what was the actual number? And was that controlled for other comorbidities or things, confounders like smoking, for instance?
Yeah, I would have to go back to the abstract to give you, I don't know the absolute number across the study, so I can't give you that. I wish I could on the fly, but we can look at that together afterwards. But again, I would answer the question the same way. I mean, they tightly controlled many other factors. Again, I'm showing you the dietary factors that there were their factors of interest, but they were controlling for many other socioeconomic factors, outside of that.
Okay, I'm going to go to the taller, smarter, better looking Dulé.
So for the fit adherence data, that was sort of very interesting to me to see that drop off sort of annually each time you do it. my question though is that the positivity rate was quite low each cycle. So are there patients who early on have negative ones that really never actually turn positive at any point in time during the follow-up? And do we really need that sort of intense surveillance for everybody if we're going to be doing FIT? So have you been able to identify predictors of people who have negative FIT and go on to have a positive FIT at a follow-up exam versus those who really never have a positive FIT and really don't need follow-up? So, you know, because I think that's the big question is who really needs that intense FIT surveillance down the road?
Yeah, again, I think your point's well taken. Within the framework of confirm, we have not looked at what you're talking about. So I think you're talking about like, you know, for someone who's had 1 FIT negative, 2 FIT negative, 3 FIT negative, do they ever get colorectal cancer, right? I think you're kind of asking like, when is the juice of ongoing FIT follow-up not worth the squeeze? We certainly haven't looked at that and confirmed. We're not even, I mean, I don't even know how many colorectal cancers there are and confirm, right? I'm still blinded to cancer data, so we haven't looked at that. But I think, it gets even more complicated than that because we're thinking about it. I'm going to come back to this, I think, in my next talk. We're thinking about FIT as a very monolithic test, as like positive or negative, but there's a quantitative data that's underlying that FIT. So there is some data to be sure. If your FIT is really 0 micrograms of hemoglobin versus 10 or 15, but still below that 20 microgram threshold, certainly the people who have a little bit blood in their stool have a different risk for subsequent cancer than people with 0. We don't really use that information in the United States. FIT is not approved for use that way in the United States, but I do think thinking about your talk and personalized medicine, of course, we should be using that quantitative data, but we don't.
I have a question for Bill. So in terms of things that you're involved with, like AI and machine learning, if you have software that you think works and you want to market it, what's the regulatory pathway? Is it 510K through device, similar through the FDA? Is it not regulated? What's happening in that space?
Well, it depends on whether it's going to influence clinical decision-making. So, you know, for example, there's some AIs that just help us with documentation that are coming out to help write our reports. And in many cases, that doesn't require any clearance. And then the others, like polyp detection, now we have an example of already approved here. And so you just need to show equivalence. With the CAD-E, I'm not quite so sure how that's going to fly.
Yeah, which is fascinating.
The FDA has a lot
See it
of,
and let it be.
yeah,
It would be nice. Yeah.
that even if it's not approved for use in resect and discard and leave alone, are people going to do it anyway? And what's the real impact of that?
Sure. In the back microphone.
Hi, wanted to get your opinion on need for colonoscopy in the younger patients with uncomplicated acute diverticulitis.
Yeah, I would say, and this will come up maybe a little bit in the next talk. I mean, I think our threshold to evaluate patients with symptoms, given all the focus on early onset colorectal cancer, I think if they have not had colonoscopy, I think you have to have a very low threshold to do colonoscopy. That being said, the data would suggest if you'd had a colonoscopy within 1, 2, even 3 years, you could make some kind of shared decision-making with that person. But I think my threshold for getting colonoscopy in a young person with recent, even uncomplicated diverticulitis is pretty low because of the concerns of, early onset colorectal cancer and even the medical legal concerns that can go beyond just the absolute risk.
Great question. Dr. Menz.
What would you say about the monolithic data that comes out of the Boston studies in terms of educated, compliant, and then trying to generalize that data to other ethnocentric groups and nationwide and even internationally? Because I've had great problems over the years, with something like that.
Yeah, really thoughtful question, and I try to give a thoughtful answer. I think it's, you're right. It's a physician's health study and it's a nurse's health study. And so it's not going to be broadly generalizable to care writ large in the United States. That being said, because we don't have, and again, I'm not making a political statement, we don't have some kind of national healthcare system. Everybody doesn't have a name and a number in this country, right? Like that's the best cohort data we have. You're right. We need better cohort data that's more representative of the general US population than a bunch of probably generally well-to-do physicians and fairly well-to-do nurses as well who live in the Boston area. We need better cohort data. Yeah.
We still have a minute or two. Any questions on the chat?
Let's see here.
Not, maybe I'll sneak a quick one into Dr. Robertson. So with the confirmed study, are you allowing for opportunistic screening or VA pop-ups that might say you're due for something? And are you measuring that as well as just the routine mailing that you do?
Yeah, so I think you're bringing up the concern about crossover of our participants, right? Crossover from people who are randomized to the fit arm to the colonoscopy arm. Major concern for us. We did do things at the beginning. So the VA has a very robust system of clinical reminders. And again, many of your electronic health record systems are developing that too, but the VA's had this CPRS system for many of you, if you trained in VAs, know what that is. And so we do a really good job of reminding people to be screened. So at the beginning of the trial, we actually suppressed those reminders because we were taking responsibility, but we also track our people fairly closely, and we would turn back on the reminders if people were not adherent. So if they were not adherent to the colonoscopy arm or repeatedly not adherent to the fit arm, we would turn on their reminders again. So
Gotcha. Great session. Thank you both.